Hello everybody, my name is Ron McCulloch and I am a consultant podiatric surgeon specialising in the condition of Morton's neuroma. Our centre offers a whole range of different treatments, and we're one of the few in the world really to offer everything from cryosurgery to open surgery, radiofrequency, ligament release, injection therapy and of course conservative care. But today's talk is going to be specifically on the use of steroid injections for the management of Morton's neuroma. We've asked our staff and our administrative staff in particular to do a list really of the questions that patients may ask about Morton's neuroma, and the hope that most of the areas concerning Morton's neuroma and steroid injections will be covered. So with no further ado, the first question that patients will often ask us is, well, what is a steroid injection? How does it work? So fundamentally, the body is naturally able to produce all sorts of different steroids in order to function normally, and some of those steroids have very powerful anti-inflammatory effects. And the adrenal cortex, part of the adrenal glands, do produce these natural steroids called corticosteroids, and really the injections that we give are a synthetic version of that type of steroid. And what it does is it's like throwing a whole load of Nurofen into the area. It's a very powerful anti-inflammatory, and that's really how they work. Now, the specifics about how they seem to help for Morton's neuroma is debated. Certainly, when you have a Morton's neuroma, generally it is associated with some fluid around it, and this is generally known as a bursitis, and often now the condition has been recategorized as a bursa-neuroma complex. So what I think the steroid injection particularly does is it targets the bursitis, the fluid around the nerve. And what it does is it reduces that significantly, albeit sometimes only temporarily. And by doing that, the pressure on the nerve is reduced and symptoms begin to improve. It doesn't necessarily break down the nerve itself, but what it can do, because steroid, and this is in some ways one of the negative effects, is they can cause wastage and atrophy. By breaking down the fat around the nerve, you are potentially giving it some more space. So that's another way in which steroids may help to reduce Morton's neuroma. But obviously, if it is just temporarily removing this inflammation, then unless you deal with some of the underlying causes, the condition is much more likely to come back. And that's why a lot of people who have steroid injections appreciate temporary benefit, but not long-term benefit. So another question that's often asked is, well, is this a good idea, or is it a common form of treatment? I would say in the UK, certainly it is extremely common, and I suspect pretty much everywhere else, certainly in Europe and the United States, as I do see many patients who travel from those countries to come and see me for some of the specialist treatments that we offer. So it is common. Typically what happens in the UK is, hopefully in most cases, patients are offered appropriate conservative care, which will work in certain instances. And I would direct you towards my specific video on footwear, as footwear can be very important to deal with the condition. But if conservative care fails, then in the majority of cases, patients would be offered a steroid injection in the hope that resolves symptoms. So certainly in the UK, yes, it is very common. So one of the other questions that obviously we're going to be asked a lot is, well, how successful is it? Is it generally successful? Now, from a study perspective, there are a number of studies which show that steroid injections can be helpful, but some of the more significant studies tend to assess the condition over a period of time, say 3 months in one particular study, and certainly during that period, steroids have been shown to help. But as I already mentioned, eventually the effect of the steroid begins to wear off, and then generally speaking, the condition will reoccur unless you, the patient, has made some changes to their lives that reduces the stress on the nerve so that the continued irritation doesn't occur. So that's really the key as to how successful it can be. It could be that somebody just changes their job or is able to majorly change their footwear or gives up a certain sport and starts a different one. So there's lots of reasons, and we'll go into detail about that in various videos and probably a little bit more here today as well. But the key to success, if you're going to rely on a steroid injection, is mitigating the underlying causes. Another example would be the right shoe, getting a good orthotic, a metatarsal pad, changing hosiery, wearing things like toe-toe socks, thinking about toe splints. All of these things can change the way that the nerve loads. So if you're going to have a steroid injection, change your behavior. Otherwise, it's very unlikely that a steroid in itself is going to resolve your problems. Now, another very important question, which isn't always asked, but which should always be volunteered by the practitioner, is what are the negatives of steroid injection. And this is very important because certainly in my practice, I've moved a little bit away from steroids, and I'm certainly using more treatments like cryosurgery to manage Morton's neuroma. And one of the key reasons for that, apart from the high success rates in my experience, are that the complications of steroid are actually more significant than some of these minimally invasive procedures like cryosurgery. Because what happens with a steroid injection, as I've already mentioned earlier, is that it will cause a degree of wastage. It can also cause discoloration of the skin, thinning of the skin, and it can also cause sometimes something called a steroid flare, which is basically a reaction to something in the steroid itself, possibly the preservative, possibly the local, we don't necessarily know, but some patients get a flare up from the injection, which can have a negative effect. So for that reason, you could have a steroid injection, but it's one of the reasons why we don't recommend more than 1 or 2. Having 3 a year and maybe repeating that is something we certainly don't recommend. And if the procedure hasn't worked, if the steroid hasn't worked during the first or second treatment, it is perhaps much better to move on to a different kind of treatment instead. So another question that is bound to be asked by patients is how painful is this injection? Well, that kind of depends on how it's done to a greater extent. If the injection is administered through the top of the foot, it's going to be less painful. If it's injected through the bottom of the foot, it's going to be very much more painful. In my view, and we'll probably cover this later, ultrasound injection should always be performed under ultrasound guidance. And for that to happen in an effective way, the needle has to be positioned in a certain way so that the actual needle can be seen with the transducer, the ultrasound machine. So I tend to go slightly between the webbing of the toe where the skin is very soft, and that really reduces pain levels significantly. But on the whole, it stings a bit, but doing it the way I do it, I like to think that the pain is very manageable. It stings, it lasts a few seconds. By most patients, it's very tolerable. What also happens sometimes is if you go through the top and go too far down, then suddenly there'll be a lot of pain as the needle hits the plantar aspect of the foot, the bottom of the foot. So there are all sorts of technique tips and ways of doing this to reduce and minimize pain to the patient. But it would be incorrect to say that the injection is entirely painless. There will of course be some moderate discomfort, despite what people might say. So another question is how long does it take before the steroid starts to have a positive effect, and how long does that positive effect last for? I think we've covered the second part, but certainly in terms of the duration before it has a positive effect, if you don't have a steroid flare, which can, as I've said, occur, then normally the benefit starts to occur immediately because of the local anesthetic that's generally administered with the steroid. Then the anesthetic wears off, and that can take anywhere from an hour to about 5-6 hours if you're using very long-acting anesthetics. And then the patient will usually experience some discomfort, and then the steroid starts to have an effect over the subsequent few days, usually. Occasionally you get a delayed effect where maybe there's a bit of irritation from the needle and the steroid, and then as a consequence, it takes a little bit longer. But certainly a positive effect is usually appreciated within 2 weeks and a maximum of 4 weeks. After 4 weeks, I wouldn't necessarily expect any benefit. One of the other reasons why it's so important to do the procedure under ultrasound guidance is because if the practitioner injects and accidentally goes straight into the nerve, then you can get what's called a neuropraxia, and you will get nerve pain that can last for sometimes months. And that's one of my reasons for being so keen on always doing these procedures under ultrasound guidance. You cannot be sure that you won't accidentally go into the nerve, and if you go deep inside the nerve, there will be a significant degree of pain from that afterwards. So another question is, am I a good candidate? Are some patients better candidates for steroid injections than others? Well, I've kind of answered that in some ways, and also it should be answered by saying who isn't a good candidate for a steroid injection. So first of all, if you're able to change your lifestyle, if you're able to make changes to the way your foot operates and functions, and that would often involve biomechanical management, such as orthoses, good gait analysis, which is one of the major things we do in our facility as well, leading to appropriate treatment to deal with the causes, then obviously it's going to be much more likely that the steroid injection will work. What I think I should cover more is times when maybe a steroid injection shouldn't be considered because of the patient's underlying situation. So one example of that would be if you have had a number of steroid injections before, they haven't worked, we wouldn't be keen to do anymore. I think it's time to move on to something else. And as I've already mentioned, things like cryosurgery cause less damage than the steroids, so why repeat steroids when they potentially are not as effective and cause more complication compared to cryosurgery? Another reason why you might not want to have a steroid is obviously if you have a sensitivity to it. Some people even have like mood changes with steroid injections occasionally. Others just don't do well with them. They've had them before. So there are reasons like that in the history that you might not want to give a steroid. Another major reason is if the patient has a significant lack of normal padding underneath the foot. So if you've got one of these feet that's basically skin and bones and there's very little natural padding, and there are a lot of people like that because they're more predisposed to neuromas in the first place, then the last thing you want to do is give a steroid which is going to cause more wastage. So bony feet, steroids are out as far as I'm concerned. Now there are also health conditions that you might wish to be a little bit careful about. I mean, obviously anything that depresses your immunity, anybody who's more susceptible to infection, patients with uncontrolled diabetes. These are not, by the way, contraindications, but there are things that would make one think carefully about, is this the right approach, and would it potentially be better to move on to something else straight away, like cryosurgery or radiofrequency, etc. So another question is, should I be considering some alternative approaches to a steroid injection? Again, it's sort of covered, but the answer to that is yes. I now do steroid injections less than I used to, and I consider all the factors that have already been discussed in order to decide whether perhaps this is a good option for somebody. There are some aspects of it which might cause you to give a steroid, even though you feel that something like cryosurgery might be better. And one of those is cost. I mean, steroids are easy to do. The patient may have a window of opportunity to have something done. It may be very urgent to do that quickly. There may be some financial challenges with having something like cryo or radiofrequency or open surgery because they're obviously more expensive. So therefore, some patients will elect to have a steroid injection for those reasons. So another question is, how many steroid injections should I have? So on the whole, there isn't a magic figure for this. It depends on a lot of things. If you've got a very, a lot of foot with lots of padding, a big foot that can cope with steroids, then you might give more than somebody who's got a skinny foot. But on the whole, we would give no more than 1 or 2 a year, and after that, I'd be thinking about other treatments that are more likely to be successful. There is no golden rule, because if you look at, for example, rheumatoid patients during the early stages, whilst they're being managed and they're being stabilized, they will often have quite a few steroid injections to get them out of their inflammatory phase. Sometimes they'll have systemic injections in the muscle or muscular injections to try and reduce inflammation. But I just think it's a common sense approach where you do as many as you think you need to, but certainly no more than 3 a year. And anybody who starts to experience wastage, so example, dimpling in the skin where you can see the dent where the steroid has caused some damage or some wastage of the tissue, stop using it and think something else instead. Another question that we often get asked is, what can or what shouldn't I do immediately after a steroid injection? We recommend that you don't do anything for about 10 days in terms of sports. But that again depends on certain circumstances. If you have a Morton's neuroma, but other than that, a fairly healthy foot without any arthritis or soft tissue damage, no capsular damage, which is the joint and the surrounding tissues, then you can be active a bit more quickly. If there is a danger that the steroid might weaken the joint, because some will seep towards the joint as well, and if that joint is already compromised, then generally speaking, we would give rest for much longer. So it really depends on the specific circumstances, but a good week of rest, no sport, for that period of time. Another question is, can I have a steroid injection if I have certain conditions, or more to the point, are there certain conditions which might stop me from being suitable for a steroid injection? Well, in this respect, there aren't many, but I think one would have to weigh up carefully. Obviously, if somebody's had an allergic response to a steroid before, then we're not going to do that unless they've been allergy tested and we know it's safe to do so. Conditions where you're immunosuppressed, like diabetes, you can still have a steroid injection, but I wouldn't do it if you're unstable. So if somebody's going for a bad patch with their diabetes and they're not being properly managed, or they're not being optimally managed, maybe just proving very difficult to manage them, or they may be going from a transition from tablets to insulin, and their HbA1c, which is the level that assesses blood sugar levels, isn't satisfactory, then we would often wait. And one of the reasons for that is that steroids can actually play havoc with your blood sugar levels. So they can alter your blood sugar levels and cause complications, particularly in unstable diabetes. And then there are other conditions where the patient might be immunosuppressed. If that hasn't been managed, say the patient's got leukemia, is being managed for is having some chemo treatments or anything like that, we're going to be very careful about providing steroid treatment without, at the very least, liaising with the practitioners who are involved in that. So there are many possible conditions. There are very few, but that would be definitive. It all depends on the general situation and the pros versus the cons. Another question that is asked sometimes is who is the best person to do the injection? Is there a particular practitioner who's going to be best placed to do a steroid injection? So my answer to that would be, without trying to be too biased, I'm obviously a podiatric surgeon, and I believe podiatrists have a specific skill in this, but I certainly feel that the injection should be done on ultrasound guidance. That would be my first thing, have it done on ultrasound guidance. And there are podiatric practitioners who use ultrasound, and there are orthopedists who sometimes use ultrasound, and there are of course interventional radiologists who use ultrasound particularly. So it's very important, for the reasons that I've mentioned, that you don't want to end up injecting into that nerve accidentally and causing a nerve damage and nerve pain above and beyond what's already there. But other than that, I think I'm trying to be neutral on this, and I think the important thing is to see a practitioner who has a lot of experience, who obviously is appropriately registered with their professional, with whatever professional body they need to be registered with, and who uses ultrasound or ultrasound guidance. I know some very good interventional radiologists who do Morton's Neuroma injections with great skill. Do your homework and look for the right practitioner who has a reputation and who specializes in the condition. Another question that might be asked, and that has occasionally been asked, is Morton's Neuroma mainly forms between the second and third, or the third and fourth toes. In fact, Morton described it between the third and fourth. So if we're being really pedantic, a true Morton's Neuroma only occurs between the third and fourth, but you can get a interdigital neuroma, which is basically the same thing as a Morton's Neuroma, between the second and third toes. So I do feel that there are differences as to why the lesion forms. With regards to the 3-4, there are often anatomical differences in the way that the nerve is presented. So it may be the two nerve branches anatomically meet in this area, and sometimes they're just thicker than other times. So there is a factor there. Whereas opposed between 2-3, when you have a neuroma between 2-3, it's much more likely to be purely biomechanical. In other words, there's just too much pressure in the area that pushes up against the nerve, which then reaches the ligament, and this is why the nerve becomes thickened, because it tries to protect itself. And these are the patients, the 2-3 ones, probably more than the 3-4, although the 3-4 will also respond to all sorts of different measures to change pressure on the foot. But the 2-3 ones in particular tend to benefit from local treatment. So, for example, steroid followed by orthoses, footwear change, lifestyle change, etc. Even more so than the 3-4 ones. That would be my experience of that. However, the other thing to remember is that between 2-3 there is more likely to be concomitant pathology. And what I mean by that is there is more likely to be other conditions as well as the neuroma. So for example, the capsule underneath the joint, the ligament might be thickened and a little bit damaged, and so on. And this is where you've got to be careful, because if the steroid seeps into a small tear in the ligament, it can cause a rupture, and that can then cause complete distortion of the toe. So this is why ultrasound again is so important. First of all, to make sure you're not missing any other pathology as well as the Morton's Neuroma, and secondly, to make sure that you're injecting the bit you want to inject, and that you avoid as much as possible that the steroid strays away from where it should be and goes into areas that it shouldn't go. So there is some difference between 2-3 and 3-4. And of course, you know, the other question I'm often asked is it more common in women? We know that it generally is, and I'm sure that has a lot to do with footwear, but we do see more and more men now with this condition, and that's partly because of sport. There are certain sporting activities that particularly predispose to the Morton's Neuroma. So this leads me to the next question, which is, are there any sports that are specific to the condition of Morton's Neuroma? And again, how does that work with the use of steroid injections? So there are certainly certain activities that massively increase the risk of Morton's neuroma, one of them, of course, being dance. So the only time we really see Morton's neuromas in very young patients is when they're dancers. Obviously because they're going up on their toes, they're driving that nerve over the ligament, and as a consequence, it's becoming aggravated, sometimes at a very early age. Now, these patients are quite a high percentage of patients are hypermobile, sometimes referred to as double jointedness. And this has another bearing on the use of steroids, because these patients often have more fragile tissues that are thinner, and they are much more likely to develop complications from a steroid injection. So, for example, very thin skin is one of the features of a hypermobile foot type, and that can lead to increased risk of a very thin discoloration of the skin over where the steroid being administered. And this is sometimes referred to as papyrus scarring, from the old Egyptian paper papyrus. And so again, I am somewhat more cautious with hypermobile patients, and a higher percentage of hypermobile patients are dancers. Then in relation to other conditions, anything that involves you going up on your toes a lot, yoga is unfortunately a risk factor. And as are activities such as cycling, road cycling, when you're locked into a cleated shoe, is another high risk factor. But this really goes into another area of Morton's neuroma, which is sport-specific risks, etc., and how they're managed, which falls outside of my remit today, because today I'm talking about steroid injections. But I look forward to doing another talk where I specifically talk about the use of treatments to manage specific sports, and there's a whole huge area to be covered there, and I look forward to discussing that in due course. I'm going to sum up now, I think. I'm sure I've missed a few questions, and if I do think of some more and my staff point out that I may have missed some important ones, then what I'll do is I'll do a follow-up video with a couple of other comments on those kind of areas. But I hope this has covered quite a large area. I hope it's useful, firstly for my patients who often ask me, and I can now send them a video which I hope will help in their understanding, but also for the wider community out there who unfortunately suffer with the condition of Morton's neuroma. We are a specialist centre, so we're going to obviously leave you with some contact details if you want to know more about the various treatments that we offer. As far as I'm aware, I'm certainly not aware of any other centre anywhere that offers the range of treatments that we do for the condition, and we have over 30 years of experience in dealing with it. So where we can help, we hope we will be able to, and I very much hope that you find this video helpful. Thank you.